And what I'm going to talk about is a little bit about types of ECMO, specifically to try and sort out the alphabet soup, VA, VV. A little bit about acute kidney injury in the context of extracorporeal membrane oxygenation. A little bit of pathophysiology, but not too much. And then I'm going to finish up with some practical tips about how to do it. Some of the things that you might not expect, some of the things that you might predict. So here we go, Veno-arterial ECMO. This is full cardiopulmonary support. This is like cardiopulmonary bypass. And when I was a registrar in the early 90s, this was pretty much a death sentence. And then with the advent of the new Quadrox oxygenator, patients started to survive for more than a day or two and started to succumb to other problems like neurological events, bleeding events, and of course renal disease. So VA ECMO is a real thing now. It's a viable alternative, commonly used when you need full cardiopulmonary support as opposed to just respiratory support. And down here on the bottom right of the screen, you can see, if we start here with the venous access cannula, there's typically, but not always, a venous reservoir. And one of the things that differentiates full bypass from ECMO is the presence or absence of a venous reservoir. There's then usually a pump. In our institution, this is always a centrifugal pump, and that's important because although it's gentler for the blood, it has a high risk of air entrainment if you connect lines pre-pump, and we'll talk a little bit more about that. Then there's an oxygenator, and it's advances in oxygenator technology which have really permitted the advances in the field. There may or may not be a heat exchanger, and then there's a return pipe, and it's the return pipe that really differentiates whether this is arterial or venous. Now, this bottom left-hand picture is a femoral arterial return cannula, and I've included it here specifically to draw attention to this little guy here. And what this is a smaller catheter pointing down the leg. And it's teed off this main return line here. And what this does is prevents that leg from becoming ischemic. And we learned to do this the hard way by getting people through their underlying disease process only to have them die of rhabdo a few days later because no one was paying attention to the limb. So if you do VA ECMO via the femoral route, make sure you put in a distal perfusion cannula. Now, Veno-venous ECMO is commonly deployed for respiratory support, specifically in our institution, severe ARDS, which we believe to be reversible. Flu season is a busy time of year for the Veno-venous ECMO program. And I was interested to hear Dr. Ferrari's talk about extracorporeal CO2 removal. We do a lot of that in our institution for lung transplant support. It's a nice way of staying off bypass to do a lung transplant, and we're starting to dabble with the idea of using it to prehabilitate people as well. Now, Veno-venous support, as you can see here, drains from a large vein, goes through the circuit, and then is returned to a large vein as well, delivers oxygenated blood to the right side of the heart. This cannula here is called the Avalon Elite cannula. It is a dual, it's like a coaxial cannula that sits and is inserted percutaneously into the jugular vein and sits in the heart. It's positioned using, in our institution, using transesophageal echo, and draws blood from both cava, the superior cava, and the IVC, and then returns it via a coaxial system straight into the right atrium where it's directed against the tricuspid valve. And the positioning of that catheter is critical, but being up in the neck, if you get this right, it does allow people to be ambulated while on ECMO, which is an important advance if you can get that. So what about acute kidney injury in the context of full support? ECMO is bad for you. 80% of people who need it go on to die. So it's not quite the be-all and end-all that people who do a lot of this will tell you. Nevertheless, without it, the mortality is 100%. Problems that specifically might lead us to develop AKI are low oxygen delivery before initiation. This is common to both VV and VA. Either your lungs or your lungs and your heart aren't working, and so you've been suffering from acutely reduced oxygen delivery. Systemic vasoconstriction, exposure to artificial membranes, generation of free plasma hemoglobin, which is a marker of the extent of hemolysis caused by the pump and the oxygenator, and the use of vasopressors in response to generalized and systemic inflammatory vasodilatation. Remember that with veno-arterial ECMO, the systemic blood flow is actually a mixture of two circulations, the patient's native systemic circulation and the flow from the circuit. Now, if that's coming from the femoral artery, remember, those are two essentially competing flows. And what they do is increase the perfusion pressure across organs. But if you've got a failing left ventricle, the last thing it really needs is 4 to 5 liters of blood flowing the wrong way up the aorta. And that can be a real problem, particularly in the context of a severely regurgitant aortic valve. Nevertheless, in general, when you institute VA ECMO, your blood pressure and blood flow generally increase. That happens to a lesser extent with VV ECMO, and the renal perfusion is affected less. Although it is true that with lower venous pressures, you tend to improve the function of the right side of the heart. This is a slide from David Ashkenazi to illustrate that the incidence of AKI in ECMO patients is sky high. It's actually the norm. 4 out of 5, 81% of people will develop some degree of renal failure. And it's predominantly rifle F. It's severe acute renal dysfunction. This graph on the right is just to point out that if you can limit fluid overload in very ill people, in general they do better. And that's going to bring me on to describe the main reason to do CRRT in ECMO patients. This is a nice survey from the KIDMO group run by Jeff Fleming at our shop. And a number of pediatric colleagues, which are well known to people in this field, David Ashkenazi, Michael Zappatelli. And they asked groups reporting to KIDMO, what do you actually do? And you can see on the bottom left here, the dark bars are North America and the light bars are non-US locations. North Americans typically do ECMO for fluid overload. Elsewhere, typically for acute kidney injury, which I thought was quite an interesting switch. And if you're going to do CRRT, what type do you do? If you're just going to do ultrafiltration, people tend to just deploy a hemofilter in line in the circuit, and we'll talk about how to do that in a minute. But if you're not, if you need clearance as well, then typically people use a machine to do that, and we'll talk about how to hook that up. And by far the commonest mode is the simplest mode, CVVH, and that reflects practice in our group as well. So the typical indications for CRRT during ECMO are the usual suspects, the AE, IOU, and acidosis, hyperkalemia. And I've put hypervolemia twice on this slide to point out that it is by far the commonest reason to do this. Typically, by the time someone needs full ECMO support, they've had several days of fairly aggressive fluid therapy. And of course, as the heart fails, as the lung fails, getting that fluid out of people is difficult. The options to do that we'll come on to in a minute. But as I said, by far the commonest indication to incorporate CRRT into an ECMO circuit is fluid overload for reasons which we've been into. It's unclear whether or not this is cause or effect. But one thing is for sure is that almost everybody who goes on ECMO has a degree of fluid overload that needs to be treated. And how do you do that? Well, your options are the same as if they're not on ECMO, right? Diuretics, ultrafiltration, fluid removal alone, or some form of clearance in combination with fluid removal as well. Now, diuretics in general are venodilators. That may not be a good thing. They are associated with worse outcomes in general with acute kidney injury, and I understand that's a pretty broad generalization. They are associated with electrolyte disturbances, particularly sodium changes and hypokalemia, and they're also associated with loss of the hydrogen ion and alkalosis generation. So by no means are diuretics the be-all and end-all. And you might think, well, if you've already got an extracorporeal circuit ongoing, it probably makes better sense to use that for fluid removal. And I'm a big believer in aggressive early mechanical fluid removal for the renin-angiotensin reasons that Dr. Costanzo was hinting at earlier on. The nice thing about ultrafiltration is it's relatively simple. Remember, this is an ECMO patient we're talking about, and quick and easy to set up. You just put a membrane or a filter in connection, which leads to the development of a small shunt in the circuit. But remember, 200 to 300 cc's in comparison to 4 to 5 liters of flow is usually not too much of a problem. It allows you to get volume off quickly, but as we've heard, that may not be in the patient's best interests, and it may be that you want to do a little and more gently for longer rather than aggressively try and pull volume off for the reasons that we heard about earlier on. It allows you to hook up to an IV pump and be a little bit more controlled in the way you pull fluid off. It doesn't remove potassium, however, but it is good, particularly if you got tangled up in a pump case using bivalirudin, for example, which is not the subject of this talk, but I would not advise anybody to do. So how do you do it? So what you do is you hook up a hemofilter literally in line with the circuit. And it's important that you think about the risks, the overall risks to the patient about where you do this. And so you can see here, the arterial access is before the oxygenator and after the pump. And the reason that that's important, and the return line is coming before the pump. Now, if this is a centrifugal pump, you really want to minimize the number of connections you have before it, because remember, it's generating a relatively low pressure, which increases the chance of air entrainment. And if this pump gets full of air, it will stop. And if this is VA support, particularly, that means the patient stops too. So air entrainment is a very real risk, and so we bend over backwards to try and prevent the number of pre-pump connections. So in practice, you can either do this by hooking up a filter in line, like on the left here, or by using a CRRT machine. So let's talk about this side first. You can see here comes the blood down from the patient, through the pump, through the oxygenator. And what's happened here is there's been a shunt rigged up after the pump, and it's returning beforehand. So I don't like this connection system as much because there are here, 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 and here. There's a lot of opportunities for air entrainment here. So we try not to do this, but in practice in adults, it's very difficult not to do that. If you're going to hook up a CRRT device, both of these connections here are pre-pump. So that's arguably even riskier. The problem particularly with doing this is, as I said, air entrainment, but the return line, if it's coming after the pump, is seeing a high pressure. And not all renal replacement therapy machines will tolerate that. Some have alarms that you can set so that it doesn't matter if it's returning into a high pressure line, but not all do. So you have to get involved with things like tubing clamps to try and fool the machine into thinking that the return pressure isn't as high as it really is. So you can do this with a formal machine. It does take a little bit longer to set up. The disposables are obviously more expensive, but again, in the context of an ECMO episode, it's not prohibitively expensive. It is safer, we think. It gives you more control. And that's why we choose to do this, even if we're just going to ultrafilter. We almost never place a separate dialysis catheter because that's usually a third great vein which is now occupied and compromised, and we believe, because we do a lot of ECMO, that it's safer to plug into the circuit. However, it's perfectly reasonable to do that. Another thing to think about is using a large bore peripheral IV cannula as the return line. In other words, you draw from the circuit, but you give back to a peripheral IV, which minimizes the return pressure problems. If you dialyze off the ECMO circuit itself, then there's problems with contamination, as I said, with air entrainment, and the circuit itself becomes more complex and arguably more to go wrong. Advantages of using the circuit are there are no separate cannulae to place. You just hook into the circuit itself, but there can be limitations, as I've said. Anytime you're accessing the venous side of the pump or the oxygenator, there's problems, the pump, sorry. Some people say you do or don't need more or less heparin. We tend to run to a PTT of between 50 and 70 anyway. And I think there are other things that determine your heparin need rather than just the presence or absence of the CRRT circuit. We do not use local citrate because it's just too complex for our ECMO team to handle. Via a dedicated line, as I said, there are fewer connections. There's less risk of contamination from the circuit itself, much decreased risk of air because there are fewer pre-pump connections. And of course, you can hook up to the CRRT machine without necessarily having to have an ECMO specialist there. Our nurses are ECMO trained, so we don't tend to have a perfusionist sit the device anymore. But the con, of course, is that you have to have separate vascular access. It's important, therefore, to know the pressures in the circuit. The access and return points are important. You try not to return anything after the oxygenator because the risk of a stroke and or an embolic event is significant then. The oxygenator also acts as a filter. As I said, in adults, and I don't do pediatrics at all, but in adults, accessing pre-pump we try to avoid, but is almost never the case. What about outcomes? So it's a little bit of a chicken and egg situation here. It's unknown, really, whether or not CRRT changes outcomes. There's no data to suggest it. It seems kind of intuitive that it would, though. And I'm a little nervous about, making it seems like it should be a good idea, so we should do it type statements. But we do know that fluid volume, excess fluid volume, is worse for you in almost every situation it's been looked at. It reduces oxygen delivery, you get increased ileus, you can get lower flows through the cannula because tissues swell. And as I said earlier on, with Veno-arterial ECMO, you can actually get lung injury from left atrial hypertension if there's competitive flow and the left side of the heart isn't allowed to function as well. There are no prospective randomized controlled trials, at least not to my knowledge, so the data is observational. It's difficult to draw conclusions about causality or association. This is a recent study a couple of years ago in the critical care literature that did a systematic review of the published evidence relating to the combination of ECMO and CRRT. And this is just one of the forest plots. This is in children as it happens. And you can see that in general, people who require the combination of ECMO and CRRT do not do as well. The summary stat at the bottom favors ECMO. And so if you can avoid CRRT, then it's probably true that the patient will do better. The trouble is you almost never can. And I think that's why I said it's a little bit of a chicken and egg situation. There's a lot of literature in pediatric ECMO in terms of the overall field. The ELSO group are very heavily represented by pediatricians, which is an interesting and welcome change. And there are some new ELSO data suggesting that just because children had CRRT for volume overload, that if they survive in the long term, they don't have any chronic dialysis requirements, which I think is reassuring. So you can do CRRT with ECMO safely, either via the circuit or via a dedicated catheter. In our institution, we always use a circuit, we always use a machine. Ideally, the connection should become after the pump if you have a machine that you can fool the pressure alarms into thinking that it's not occluded. My own bias is to do this early, maybe even prophylactically, because I have seen fluid overload over the last 20 years of my career repeatedly cause problems. And I think that the equipment is better, the oxygenators are better, but as always, the devil is in the details. So thank you very much for your attention. Have we got time for a few questions and answers?
I think we do.